Hi, good morning, everyone. Thank you so much for the opportunity to be here. Uh, in sharp contrast to the fantastic, highly technical presentations that we've seen this morning, just absolutely fantastic. This will be much more kind of on a basic level. I'll first start by giving a quick introduction to SANS, and then go into some of the testing that we perform to specifically follow this syndrome. So again, thank you so much for allowing me to be here. So SANS, let's talk a little bit about the syndrome. So you have to start by first talking about spaceflight. So the International Space Station, which you can see in the lower left corner there, the expeditions began back in 2000. So it's been ongoing for over 20 years. And this meets the definition of long duration spaceflight. Long duration spaceflight is any spaceflight greater than 30 days duration. On board the ISS, that's typically about 6 months. It's interesting to note that although we as humans have been exploring space since the early 60s, the first SANS case wasn't discovered until after a flight in 2005. There's a clue there, meaning that we believe that duration of spaceflight is what drives SANS. So the current case definition for SANS is the development of one or more of the following new signs during or immediately following spaceflight. That's optic disc edema, chorioretinal folds, globe flattening, and or a refractive air change of at least 3/4 of a diopter. I call these the big four. These are the big four signs that are, number one, associated with SANS, but number two, present some type of risk to the crew member, to their vision, either short term or long term. So for everyone's awareness, SANS affects both males and females, and it can occur in either or both eyes. Luckily, currently, we have no evidence of any permanent vision loss in any crew members, whether that's short duration or long. However, the earliest signs of SANS are detected in 69% of the long duration crew. You can take a look at the histogram in the bottom. All SANS findings fall at 69%. It's overwhelmingly driven by optic disc edema as measured by the OCT. We take a look at the total retinal thickness in the peripapillary area, and if the edema, if the change in thickness exceeds or equals 20 microns, comparing pre-flight data to on-orbit data, we diagnose that person with optic disc edema, and obviously we follow them a little bit more closely than folks without that edema. But you can see the chorioretinal folds, the globe flattening, a change in refractive error, those fall somewhere within 15 to 22% of prevalence for the population. Some of these changes can become permanent, and I'm specifically talking about globe flattening, hyperopic shifts, and then choroidal folds. If you take a look at the OCT image in the bottom, I'm sure the audience already knows, but that bottom bright layer is the RPE/Brooks membrane. And in the great overwhelming majority of terrestrial humans, that is very smooth, a nice smooth surface. You can see here the gentle kind of undulations that are in this particular post-flight crew member. But what's interesting, especially interesting here, is that this is a long duration crew member who last flew on Skylab. That occurred in the 70s, way past 40 years ago. This crew member, once NASA obtained an OCT device, he was diagnosed with mild choroidal folds in both eyes. A little bit worse in this eye, the right eye, than the left, but they're nonetheless. I also need to note that there are brain structural changes that are also associated with long duration space flight. However, at this point, they're not yet linked to SANS. And luckily, we've detected no cognitive losses in any crew members due to these changes. What has been shown is that long duration crew members, when they return to the planet, they receive an MRI, and it appears that the brain itself, in several different studies, the brain itself displaces upward slightly, and the lateral ventricles enlarge slightly, maybe 10 to 15%. Obviously, we're monitoring this, and we're studying this. So SANS, bottom line, it is a top human physiological risk to long duration spaceflight. It could lead both to short-term and or long-term vision changes, and potentially could cause cognitive or other health effects. But right here, right now, our primary concerns are visual field defects that might be induced because of the optic disc edema. If that's there long enough, at enough of a severity, we may expect to see visual field defects that are temporary or permanent. Also, distorted vision is another possibility because of the chorioretinal folds. If they occur, especially in the macular area under the fovea, we may see distorted vision. The severity of SANS is thought related to the mission duration, as I've mentioned. Before ISS, most spaceflight was short duration. The space shuttle, typically those were about 14-day missions. And in the prior missions with Apollo, Mercury, Gemini, those were typically short duration as well. And although there were some anecdotal reports of vision changes during those flights, nothing really surfaced, certainly no significant signs that were detected post-flight. So the ISS missions, as I mentioned, are usually 6 months long, and that is where we've started to see SANS signs. Now, what this means is that exploration missions, for example, a mission to Mars, those will be a longer duration, maybe up to 3 years, and there is a corresponding increase in the SANS risk because of that. So let's talk about the medical surveillance that we're able to perform. This is a high-level view. We do more than what I show, and it gets a little more in depth, as you can imagine, but we do have a limited time today. But keep in mind, the astronauts' eyes have been examined pre-flight and post-flight since the earliest days of space exploration. In the bottom, you can see pictures of the Mercury 7 astronauts being tested. And this happens even today. Maybe not in the same way. We don't typically poke the eyes quite the same way, but we collect data nonetheless. Since SANS was discovered in 2005, the medical surveillance of the eyes has evolved. We performed inconsistent testing until 2010. And at that point, the monitoring was standardized. And most importantly, in-flight testing was instituted. This is very critical. You also need to keep in mind that crew time is probably the most precious commodity on board the space station. And although medical testing is incredibly important and everyone acknowledges that, still, it competes with many other top priorities. For example, spacewalks, EVAs, even maintenance. You have to maintain the ISS. And so we cannot dominate the time of our crew members. We cannot dominate the space of the ISS. We have to be quite conservative and precise. So the underlying premise of our medical surveillance is we feel it is very critical to compare in-flight to pre-flight data, and that allows us to detect any acute anatomical or functional changes. And it's also critical to compare post-flight to pre-flight data, and that gives us a view into any potential chronic or permanent changes. So let's run through some of the testing. The primary SANS test. The first is a 3 Tesla MRI. If you look at the table on the top, you can see this occurs only pre-flight and post-flight, simply because that device is so big, so heavy, big magnetic field, we just simply can't deploy that to the ISS. But we use a special NASA astronaut protocol. You can see some of the example images. The lower left are pre-flight and post-flight images of the brain showing a constriction of the sulci, which indicates the brain physically moving upward. If you take a look at different views, you can actually see the brain does displace upward. The middle image shows potential optic nerve tortuosity, potential kinking. And then the one on the right shows pre-flight and post-flight images of the globe, where you notice a significant flattening of the globe post-flight compared to pre-flight. But if you've got a sharp eye, you might note that the pre-flight images, they also show a little globe flattening. Well, that crew member actually did a space shuttle mission before the pre-flight images here, and we believe that that globe flattening is due to that 14-day mission. But you can definitely see the ISS mission affected the posterior globe shape. Visual field testing, we perform a 24-2 CITA standard. This is performed pre-flight and post-flight. We do plan to deploy a device in 2022. And if you look up on the table, you can see the on-orbit testing frequency. FD30, that stands for flight day 30. Flight day 90 is next. And then return minus 30 days. So 30 days before they return to the planet, they also will obtain this test. But again, we don't have that capability up there quite yet. So you can imagine these crew members, after they've been up there for 6 months, they come back, they are completely exhausted, and we put them immediately into the chair for medical testing, including ocular testing. We attempt to do this within 24 hours of landing, 1, 2, or 3 days post-flight, but as soon as possible. You can imagine these folks are extremely fatigued, and you know, a lot of physiological changes happen during space flight that induce this fatigue as well. But if you look on the right, we have an example of a post long duration space flight visual field. This one indicates an enlarged blind spot that corresponds to a Frisson grade 1 optic disc edema that occurred in both eyes. I'm just showing the right eye visual field here. The good news is that both the visual field defect and the optic disc edema did resolve by 6 months post-flight. And because space is a premium, we are developing a goggle-based visual field device that you can see there in the bottom, and that is meant specifically for exploration space flight, so deep space, potentially heading to Mars. We certainly can't send up a large-scale commercial product like, for example, the Humphrey. It's just too big. We also perform a vision screening. This little segment not only occurs pre-flight and post-flight in association with a full comprehensive eye exam, but this segment occurs on orbit flight day 90, 30, 90, and return minus 30. This comprises uncorrected and corrected visual acuity conducted at distance and near. Especially the near visual acuity is highly sensitive to the hyperopic shifts that occur in many of our crew members. It's one of our first indications that something's happening. AMSR grid is performed, and really the main role here is the test for any visual distortions that might occur because of chorioretinal folds. A vision questionnaire is performed, asking about, has your vision changed? Are you using different glasses, et cetera, et cetera. And I will say that there are probably the most frequent finding is reports of decreased near visual acuity when you don't have a new pair of glasses or contact lenses to go into with more power. And so about 23% of short duration crew will report a decreased near visual acuity, and that forces them to move into a higher power pair of glasses or correction. 57% of long duration crew report the same thing. And so again, that gives you an indication that there is a connection with duration of flight to SANS. Ocular ultrasound occurs across the board, pre-flight, post-flight, and on orbit. I call this our on-orbit MRI alternative. Like I said, we can't get a big MRI up there, so ultrasound does a very reasonable job for what we need it to do. This requires an on-orbit subject as well as an operator. And those terms, what they mean is the subject is what we would probably call a patient. You can see that the patient here in this picture is applying the probe to her eye. And then we have an operator, a second on-orbit astronaut who is operating the device that captures the data, whether that's an ultrasound device or that's a laptop connected to an OCT, etc. So these folks, neither of these folks here are physicians, they're not ophthalmologists, they're not optometrists, they're not ophthalmic technicians. So they are trained how to do this, but it's not their primary job. They've got a few other things to do. And so when they're collecting these data, it's been several months since they've even seen this device. And so they are supported on the ground from Johnson Space Center Mission Control by a remote guider. That's the person who talks with them. It's usually the person who trained them in the first place. And then there's also a subject matter expert down there right next to the remote guider. That person's job is to give thumbs up or a thumbs down on the quality of the data. Do we need to recollect, or is the data good enough to move on? Key data that's collected here: optic nerve sheath diameter. If SANS is related to increased intracranial pressure, the optic nerve sheath diameter may increase. We also look at blood flow in and out of the eye. We look at the globe shape. So you can take a look at the lower ultrasound image here, and you can see a general flattening of the posterior side of the globe. We also look for optic nerve head protrusion, which you can see in the ultrasound view on the right-hand side there. You can see how the optic nerve head is protruding into the vitreal space. And if you have a sharp eye here on the lower image, you might detect optic nerve tortuosity, maybe kinking. So again, that gives us an indication to keep a closer eye on this particular crew member. So kind of an ISS fun fact is that most of us are aware that when you perform ultrasound terrestrially, you typically use a gel, and that creates a better interface. Gives better data. Well, it costs between $10,000 and $20,000 to deploy per pound to deploy anything to the space station, and ultrasound gel doesn't really serve any other purposes. And so it's a very big investment for little usage. And so one of the amazing crew members up there, Don Pettit, he thought, well, what about water? Could water do this? Sure enough, he squirted some water. It attached, it adhered to the front of his eyelids because of surface tension. And water, wouldn't you know it, it's a perfect substitute for ultrasound gel. So there's plenty of water up there. And so this is what we use routinely for ultrasound testing. OCT is our most important ocular diagnostic device. It's highly sensitive to anatomical changes in the optic nerve head and retina, as I think everyone on this call is aware of. This also requires an on-orbit subject, as you see in the picture, as well as an operator to hit those laptop buttons and to help adjust the position of the OCT camera. It's also performed with ground support from a remote guider and a subject matter expert. A ISS fun fact here is that you might be familiar with standard OCTs having that joystick controller to adjust the camera placement, similar to the joystick controller on a slit lamp. Well, that is completely ineffective in microgravity. You can't use a joystick because it requires weight to move. And so the on-orbit OCT device that we use requires direct gearing. You can't really see it because Mark Vandehei here is actually rotating those knobs, but we've got 3 knobs that are directly connected to the gearing to move the camera in the appropriate direction. So that works quite well. And OCT is performed pre-flight, on orbit, and post-flight. So the data set for the OCT, we perform 4 scans per eye, and 2 of those are 20 by 20 degree block scans, each with 193 B scans lines. The one, as you see in A, is centered over the macula, and then C is the version that is centered over the optic nerve head. And then B is a 15-degree diameter hybrid scan that is centered over the optic nerve head. It includes 48 lines of a radial pattern, as well as 5 circles of different diameters. And then finally, D here, delta, is a 10 by 10 block scan, very small, with 261 B scan lines. It's centered over the optic nerve head. And as you can imagine, its main intent is to very carefully study the optic nerve head because most of the changes we see are centered there. Some general findings with the OCT, we generally, I think in pretty much every case, we see a general thickening of the choroid. Underneath the retina, the vascular bed, it thickens. It's not a universal thickening, but on average, it does thicken. So in the graph here, you can see a heat map of the delta, the change from pre-flight to in-flight in choroidal thickness. Red indicates a thickening of the choroid. Blue indicates a thinning. And you can see how it's not uniform, but overall there is a thickening. If I didn't mention, the optic nerve head is here centered in the middle. Another general finding is we see changes in the optic nerve head. So we've got a single line scan going from the fovea across the optic nerve head. You can see that cross-sectional image here on the bottom. This is a pre-flight image, and you can see, I call the choroid the fluffy cloud layer, and you can see the top edge of the retina flowing into the cup of the optic nerve head. So just for convenience, I've made a yellow line down here that indicates the internal limiting membrane going down into the cup, and then a red line indicating the rough edge of the choroid. So if we now go from pre-flight to in-flight, and I'll flash back and forth, pre-flight, in-flight, pre-flight, in-flight. If you take a look at the lines, you'll see that there is a general amount of edema that occurs in the optic nerve. What happens is the cup actually gets kind of squeezed. The optic nerve cup will actually get a little bit smaller in some cases because of the edema in the optic nerve head. And then the peripapillary area also gets edematous if the edema is significant enough. But you can see how that definitely changes. And then down here, you can see some areas of the choroid that have extended to indicate a thickening of that tissue. And this is quite typical. And back using our previous definition of SANS, this actually was not a SANS case. And I haven't gone back to check to see if this person does fall into our current definition. But it was interesting that before you had definite signs of edema. However, that was not a SANS case back in the day. So upon return, I can't recall how many months this was post-flight, but you can see that the retina and the choroid in this particular case has gone back pretty much perfectly back to normal. We have not detected any loss of nerve fibers or things of that nature in any crew members at this point. Another example, well, I'll show you some examples here. These are chorioretinal folds. So this is pre-flight on the left and post-flight on the right. If you notice, sharp eye there, you notice these slight undulations pre-flight. Well, you may have guessed already, this person flew on the space shuttle previously, and we believe that those choroidal folds are due to that short duration space flight. But certainly if you compare pre-ISS to post-ISS, you can see a tremendous change in the inner limiting membrane with retinal folds and choroidal folds down below with very sharp edges occasionally. And notice that this is immediately under the fovea, certainly under the macula. And this patient or this crew member, along with all other crew members, have never reported any distorted vision. It boggles the mind, but I think that indicates the amazing ability of the brain to adapt to anatomical changes, as long as those changes don't happen too quickly. So retinal photography, this occurs pre-flight, on orbit, and post-flight. This is not as sensitive as the OCT, of course, in detecting those fine anatomical changes that we talked about, but it's extremely important to document from a quote-unquote bird's eye view of the posterior pole. You don't often get that full view with the OCT. This gives it to you. Historically, retinal photography was performed via a fundoscope, like you see in the example picture here. But currently, to save crew member time, we now obtain retinal photography through the OCT's multicolor imaging capability. And you can see an example of that there. Color photography is still available if we need it. This procedure requires on-orbit subject and operator, and also ground support from a remote guider and SME. Examples of choroidal folds, if you look, you can see some lateral undulations there, some darkness and lightness going straight through the fovea, both in the left and right eyes here. So take-home messages, I hope I'm on track here. So again, currently we have no evidence of true vision or true cognitive impairment in any astronauts, short duration or long. However, we do detect the early signs of SANS in 69% of ISS crew members. That is, we look for that first indication of optic disc edema, chorioretinal folds, change in cycloplegic refraction of at least 3/4 of a diopter, and or a development of globe flattening. SANS severity is thought related to mission duration. Therefore, SANS poses a significant risk to deep space exploration. For example, that 3-year Mars mission. It is highly critical to collect not only pre-flight and post-flight data, but of course we need in-flight data. We use that to diagnose and track SANS. We use it to monitor countermeasures, how well they're working. We use it to detect any long-term health consequences. But these tests have to be very, very precisely selected. We can't do every test in the book because the crew time is highly limited. We're directly competing with other operations. The space is highly limited, and there is a tremendous cost to deploy these items, as well as the ground support to run these tests. We also face other challenges. First of all, we still don't know the true pathogenesis or pathophysiology of SANS. We do know that SANS is unique to spaceflight, and unfortunately, we have no perfect equivalent terrestrially. Increased intracranial pressure, IIH, is not quite, it doesn't present the same way. So we can only gain some potential clinical research pearls from it, but it's not an equivalent. Medications that might be effective on the ground can have totally different pharmacokinetics once they're in space, and so it takes careful consideration to even think about using these medications. There are also confounding variables. For example, the CO2 up on the ISS is about 10 times what we're experiencing right here, right now on the ground. The crew members typically intake a lot more salt up there than they do on the ground. that can affect the data. And then the exercise type and levels. If you're lifting weights up there, that's basically a version of a Valsalva, and that can increase the intracranial pressure. And if ICP plays a role in SANS, that could make things worse. And potentially one of the bigger ones here is that we simply have a low sample size. We don't send a lot of people up into space, and that includes females. Our sample sizes are especially small for them, but also other ethnic groups. And so we are collecting those data, we're gaining, and we're learning more information. But I believe I'm getting pretty close to the end here. So with that, I would be very happy to entertain any questions, or we can save them to the end, whatever Dr. Marsek prefers. Thank you for your time.
Thank you. Thank you very much. That was wonderful. We do have a couple of questions. I think given the overall, the full spectrum of risks associated with spaceflight, where does NASA place the SANS risk in terms of maybe achieving the long duration exploration missions?
That is an absolutely fantastic question. So typically, things can move and shift, but I believe that NASA's human research program is still focused on, I believe, 33 risks, and SANS is typically falls in the top three, sometimes juggling in there, typically in the top three of the top human physiological risks to spaceflight, especially as we talk about missions to Mars.
Wow. Okay. Wow. Yeah. Wonderful.